are we? Still a clicker here. Thank you. All right. All right, well, good afternoon. So we'll go through this pretty quickly. You'll get the whole slide set. I've got more slides here than we can cover in the next 3 hours. So, we'll go pretty quickly here. So, oh, the left button.
It's a mouse.
Whatever. All right, so I do want to thank Dr. Susan Hatters-Friedman, forensic psychiatrist like myself, who I had seen a brief, very, very brief talk on Munchausen, so I borrowed a few slides from her. I just want to thank her for those from Case Western. So basically, you've heard of the phrase Munchausen syndrome. DSM-5 has tried to work with this a little bit to make the diagnosis a little bit different. So initially, we talk about what's called factitious disorder, and I'll distinguish that later from malingering. Factitious disorder imposed on yourself is Munchausen syndrome, and then factitious disorder imposed on another person is going to be considered Munchausen by proxy, which is the phrase you often hear in the literature. So this is the DSM-5 criteria. The person is making up, creating psychological or physical signs or symptoms, or inducing what appears to be a disease or an injury associated with identified deception. So this is where we know that they're faking it. It may take time to figure that out. Once we've identified that, then it becomes clear that it's a factitious disorder. So it's not obvious in the beginning, and for clinicians trying to identify this, it really can be a challenge, and that's why this gets, I think, a lot of press, because people can do this for years with themselves or with the child, and it may take time before you find out what's going on. So the person comes in, they present to themselves, again, this is doing it to yourself, as injured, ill, or impaired. It becomes evident, not necessarily right away, but to make the diagnosis, you have to determine it was deceptive behavior. And there isn't an incentive, meaning that they are not doing it for a particular obvious gain. They're not doing it for money. They're not doing it to get out of doing something. And so it becomes this idea of factitious disorder, which is really unconscious motivation, if you will, to think about it from a psychodynamic perspective. And then the behavior, like many other DSM-4 and now DSM-5 criteria, is not better explained by another mental disorder. So it's compulsive. These individuals, because of the drive, can't help themselves. They crave hospitalization at times. They crave the sick role, is the way people think of this. And obviously, they are getting something out of the sick role. If you think about it when you were a child, and think about it even as an adult. When I get ill, and I have a head cold as we speak, you find yourself kind of wishing for your mommy, right? You were in that role because when you were sick, your mother did. I still remember when I was probably kindergarten, and I remember distinctly this time of year getting sick, and my mother made gingerbread cookies. And somehow that always pops in my head when I have a head cold. That positive sort of feeling is there. So you do get things out of being sick. Well, obviously there's a lot of negatives to being sick, but you do often in our society get a lot of positives out of the people around you who care about you because you are sick. And so these people often have been shown now when they study them to have a fragile and fragmented self-image. And they might even end up with psychotic or suicidal episodes where they're thinking about attempting suicide. And I've not seen a lot of literature where they actually go forward with the action of attempting suicide, but they may, in the course of trying to create their illness, end up leading to their demise. So that obviously is a risk with these individuals. They will undergo extremes to maintain the sick role, this factitious disorder. They will even go through limb amputations, organ removal, or even potential death to maintain this masquerade. So the point being is they really are driven by this unconscious component that they would certainly not be doing if it was done just to get out of doing something or to gain something more tangible like money or a lawsuit or that sort of thing. And there are individuals who then you'll be trying to do with a differential diagnosis, as we call it, and you'll find out they will eventually admit it, here's what's going on. They tend to not actually have factitious disorder. It tends to be malingering. So malingering is a separate issue. Basically, malingering is the fancy word for faking. And they're usually doing it. So when I'm used to moonlight the prison setting, they would fake an illness to get out of doing something, like a certain task they were asked to do, cleaning the cell block or whatever. They would do that. Or maybe they hoped to go to the hospital just to get out of the environment because somebody was threatening to harm them in the prison. That would be malingering. We saw that sometimes in the state psychiatric hospital. Somebody would try to malinger a mental illness to get found not guilty by reason of insanity because they felt that was going to be a better outcome for them than going to prison. And hard for them to accomplish that 24/7 in a psych hospital where they're being observed, because even Angelina Jolie can't act that well 24/7, right? So you're going to get caught, as they always did. So that's the version of imposing it on yourself. These are the 4 main ways it gets identified. They're discovered, right? So you see them heating up the thermometer. You walk in on them in the doctor's office and they've just heated the thermometer up. So now they have a temperature of 104, which would be very concerning in an adult. What's going on with this person? Well, the truth is they are probably 98.6, which is normal, and they're heating the thermometer. You catch them. Maybe you find the incriminating items. Maybe they're injecting something that would create these side effects, or there's pills that would create the side effect, but in the absence of pills, you're assuming it's actually a sign or a symptom, not a side effect. The laboratory values may not match what you're seeing as an organic etiology, as what's going on with an illness. And of course, it may be made by exclusion. You've done every test, and these people often, maybe they even gain from that. They get the $1 million workup, and there's nothing. Absolutely nothing. And then, of course, there are probably illnesses we've never discovered that'll fall in that category, and so maybe it's not factitious, but by and large, when you go through this list, you'll figure out it's factitious. So the Munchausen, and by the way, his name was officially spelled with 2 H's. They dropped that H, as we call it, Munchausen's disorder. So he was in the Russian cavalry, a German by background, but he would talk about his amazing exploits from the war. And generally, people eventually figured out they were imaginary. He made them up. He told all sorts of tales of woe and wonder. And of course, he's the subject, therefore, you can see him as of a movie and some books and things of that nature. At age 74, he did marry a 17-year-old, so she apparently loved his stories. Weirdly, it was a weird relationship. He spent the wedding night alone. His wife did give birth to a baby, but the baby died suspiciously at 1 year under strange circumstances, which again plays into what might have been going on through the Baron's mind there. And the belief is, as people look back in history, is that he actually had factitious disorder himself. Okay, so that is if you're doing it to yourself. If you're imposing this sick role on somebody else, they call that factitious disorder imposed on another, or FDIA. You'll see it abbreviated sometimes in the literature. You're, again, same idea as the other ones. I won't belabor this, but you're imposing it often on your child. And it's often the mother imposing it on the child. It can happen with fathers. It's much more rare. The mother will impose it. And of course, now the mother is getting something out of this by being the caretaker of the person who's so ill. And so she is actually getting the attention as well as the child, the flaw being that the child may end up being very seriously harmed in the course of this. The child's not interested in an amputation for the sake of this unconscious drive, but the mother may not be able to stop herself going down that path for, again, the same criteria as you see when it's imposed on yourself. It is not officially child abuse in the sense of what we think about as child abuse, but it certainly falls under the category of child abuse. So these individuals can be arrested and convicted for child abuse because it often goes way beyond neglect. If anything, they're giving their child lots of attention. It's not really neglectful, but it really is an abusive thing because they're putting them through tests and maybe even operations and so forth. And often they lose their childhood over this. So they're not even in school very much because the mother's making them ill by giving them pills and other things that lead to that. About 20% of people, and this is Munchausen syndrome by proxy, MSBP, which is the same as FDIA, have signs of Munchausen's themselves. So there is some research on this. So you may have the Munchausen's yourself, and maybe, in fact, you've played that out at some level with your physicians and your other care providers, but now you're imposing it on your child. And unfortunately, they often find, because we tend to really care even more about kids and adults, they find they get even more of that sick role reinforcement out of their child being the one who's so ill. So this kind of breaks this down to give you the concept here of a somatization disorder, factitious disorder, and malingering, which I've mentioned. So somatization disorder, big category in the DSM-5. We see this as completely unconscious. They're getting the patient role, but they're actually creating the symptoms internally. They're not imposing them consciously. So, whereas factitious disorder, they're actually heating up the thermometer, or they're taking the blood pressure pill, which drops their blood pressure, and you go to the doctor's office, and he or she can't figure out why you're so low in blood pressure. And in the absence of a medication, they do all sorts of tests trying to figure out why you're low in blood pressure, when the truth is you're taking a beta blocker and your blood pressure as well, that kind of thing. And then malingering is much more conscious. They're looking for external gain, again, usually either getting out of something or getting money in some fashion. And they tend to avoid the painful or risky behavior, whereas in the other two categories, they accept that painful, risky behavior, again, up to including death at times, trying to deal with this. So here's just a sense of symptom categories. Again, I won't go through this in detail for time's sake. You'll have the slide set. But again, claiming your migraines when your child has just headaches, right? So you come in as the mother, maybe the child does occasionally get a headache. You're now exaggerating this. And of course, there's going to be a lot more attention if it's a migraine, because we're still learning more and more about what even causes migraines. So there's more tests. You're going to get a neurology consult. You're going to get a lot more attention than if it's a headache where you give Tylenol and it goes away. That most of us wouldn't even go into the doctor for that. False reports, false signs. They might even teach their children, again, through reinforcement. Oh, you did that so well, honey. They'll fake a seizure. So a pseudo seizure. The child might even learn to do this at a very young age, not knowing what was going on in this dynamic with their parents. Of course, I've talked about injecting the child with things, even including bacteria, right, which of course could be deadly if it ends up in the bloodstream, could be a sepsis, and they could die from that. And maybe the parent doesn't know that. I'll say it again later, but the research does show that often these mothers do have some medical background. So a good percentage of them are nurses. Or have other kind of backgrounds like this. They do have some idea about illness and what will get them more attention from the care providers than otherwise. So the warning signs are not really rocket science. It's just that it's hard to tell when you've got what appears to be a mother in front of you, or for either on herself or for her child, seems to be intelligent, telling you the details of the symptoms and whatever's going on, and you're going to take it seriously, right? We want to trust our patients. So you're going to go down that path initially in a very honest fashion, first do no harm, and then trying to do help. And the problem with that is eventually you start to realize, well, something's not right here. Gee, I've even thought about all the so-called zebras, that is rare illnesses, and we can't figure that out either with $1 million test, and you have to start looking more for these warning signs. So the hope from today's lecture is that all of you out there already treating people, you'll think more about these potential warning signs even now, and maybe catch it before their child or themselves gets ill. There is a common one now, especially because of the increase in food allergies, for mothers that are doing this Munchausen's by proxy or FDIA, to allege that their child is allergic to certain foods or maybe medications, and then that gets played out, and they'll do that even in public settings. If the child goes to reach for the peanut butter, they will leap on the child and push the peanut butter away and maybe scold the other parent who's about to give their child peanut butter. And again, they get something out of that whole drama, if you will, even though the child, as it turns out, isn't really allergic to peanuts in that case. So this just gives you more of a list. I mentioned the pseudo-seizure potential, very rare disorder symptoms. Although children can have rare disorders, by definition, they're rare, right? So it shouldn't be that this is an ongoing sort of issue. So if you look at the literature, this is a fairly recent review from Gates and Bass, and they looked at a lot of cases. So this took a lot of work to find almost 800 cases. You'll see, again, as I mentioned, the vast majority of the perpetrators are female, and then almost all of them were the mother of the victim, or we're calling them the child, in this case, a victim, which they really are a victim of abuse. A vast majority are married, and I'll talk about the fathers in a minute. You can see that it tends to be a mother. Makes sense. age 27, because that's the kind of right age if you're having children, and now the child's still young enough that you can impose this on them without the child saying, wait a minute, I don't have any of that. It's going to be hard to impose this starting at the age of 17. It's going to happen at the age of 7, right? So it's going to be a young age, maybe younger. 46% in the healthcare profession, these mothers, right? So they've got some knowledge. They can more easily fool the doctors, nurses, pharmacists, and others that might be coming to see them in a hospital setting or in a clinic type setting. And then you can see that maltreatment in childhood occurred in a lot of these mothers themselves, not necessarily Munchausen by proxy, but they did have some kind of maltreatment. And then you'll see that about a third have factitious disorder themselves, on themselves, as well as, of course, these are all people that are doing it to their children. A couple more epidemiological findings here. The concept of this was actually first officially described in 1951, so it was not described when Baron von Munchausen was alive. That was a look back in the literature to find where we ever seen something like this before, so that happened later. You can see that most of these studies are estimates, 2 to 4 cases per million in the general population, so it's not that common. So if you're an individual pediatrician or family medicine physician, you may see some of this in your career, but not a huge amount. Most of us are not seeing 1 million patients in our career, right? So we're not going to see 2 or 4. So it's a tough one, but these are estimates. Very hard to know how much of this goes on at a lower level where maybe the unconscious drive to be a good parent keeps them from getting their child too sick, and yet they actually have created some of this to be in the doctor's office more and so forth. Boys and girls equally affected, much more common in the Caucasian population than in other populations. Oftentimes occurs at a young age, so 4 years old, and you'll see here that 6% do end up dead from this. It's very, very serious and very, very important we identify it early on for these individuals, and another higher percent than that even get long-term injury of the ones who do survive. So just real quickly, a few of these slides, just to give you, if you want to learn more about these from the literature, these are ones that are pretty good. Sharp Objects, which has actually been done twice now in 2006 and 2018, talks about, particularly about Camille, and she goes to her childhood home to look at the story, and she finds, we learned that her childhood included the sickliness and death of her sister, which is shown somewhat in this film, her attention-seeking mother. She ends up with her own alcohol and cutting, and then Adora, the mother, is doing this Munchausen by proxy, or FDIA, and it's really well portrayed with good acting in this. So that's a place to sort of see that.
It's a great watch. It is hard to get through.
It's hard to watch.
It is hard, but it is worth it. It's very well done. If you like film.
Right, and this was based on a real story. So a pediatric nurse had actually written a report in the past about this, but it was disregarded as petty because she happened to not have any children herself. Talk about a bias, right? Oh, you don't know anything, you're not a mother. And they just ignored it, even though meanwhile terrible things were happening in this family. So just a little bit of a backstory on how tough this is, because we don't want to believe it. Again, we go into healthcare with good hearts and minds to try to help people. We assume they're coming to us genuinely wanting help with their problem. And the idea that their unconscious mind would be trying to drive them into a sick role is really hard to wrap our minds around. It really is. Sickened is another one where you end up with this concept of doctor shopping, going from doctor to doctor. I've got these problems, I've got these problems. I want to make one quick aside here that it is certainly possible there are individuals that have either depression or have a psychotic illness where they have a delusional belief that they have something wrong with them. That would be a different category, but that does happen. People with major depressive episode may feel like their insides are rotting, and they will come in repeatedly wanting to learn if they have cancer somewhere. And it's really a somatic symptom of that terrible black cloud that they feel around them of depression. Similarly, you could have a delusion which falls into a more negative sort of nihilistic delusion where you feel like something's going on, and you, as a delusion, you will not be talked out of this, right? So because it's a delusion, so you're going to go through lots of treatment. So it's a very different thing. That's usually on yourself. That would not be imposed on another. Both of those examples would be on yourself. Okay, so subcategories have been looked at in 1986 and again in 2010, just to give you a sense of, so help seekers, doctor addicts, and active inducers, which are the ones who, of course, are harming their child to induce these symptoms that aren't actually really symptoms. They're really side effects of whatever generally the mother is doing. So researchers are trying to learn this better, like we do in science. We try to break it down so we can then come up with a better way to identify and treat people. So that's the concept behind that. Again, the motivation, escaping from painful experiences from the past. So they might be reiterating kind of what they went through as a child in about a third of the cases. They feel more powerful, right? Hey, they're part of the treatment team now. Here I am, and I'm here with my child. I'm going to help you with my child, even though I'm actually creating the problems with my child. And they might feel a sense of power from what they may feel power over their child, which I would argue parents have that anyway, but they clearly don't feel that way. So they're creating a different sense of power over life and death. They may get a thrill from deceiving professionals, right? Maybe, again, that's where the being a nurse comes in. If you have that knowledge as a nurse, it's not going to be as hard to deceive the other nurses and doctors and pharmacists and social workers around you because you know enough to do that, at least for longer than the lay public would know how to fake something. So the fathers, I do want to mention that real quickly. In these families, it's been shown they tend to be very passive role. They tend to be workers. They're out of the house, making the money, and the mother is there doing the nurturing, and they're happy to, so if you will, a traditional sort of family from the 1950s, for example, and so they're really in the background. And so they might not at all be aware that the sick child isn't really sick. They are really also kind of, their heartstrings are being pulled because they also believe their daughter is ill, and the mother's doing, oh my gosh, honey, you do such a great job taking all these doctor's appointments. And, oh, I'm glad you can do that because I got to work to pay the, you know, you can imagine how that would play out as maybe even a unifying feature for the couple. And that may be another drive that's I've not seen addressed in the literature, but you can imagine how that might be a way to pull the couple together if they're united against their child's illness.
Yet it's abuse of that father.
Sure. So now, right, so the father's being abused emotionally, the child's being abused emotionally and physically. It's terrible when it happens. So I think I've covered most of these. Eating disorder I did not touch on, so that's in there in the literature. Personality disorder, not surprisingly, there may have been issues. Personality disorders tend to come from upbringing type things, we believe, so there may have been something going on in their life, abuse, neglect, what have you, that contributed to that. I should say use, not abuse, but substance use disorders do also fall into this, so maybe they're also taking their own drugs and doing other things with the child and so forth. Okay. All right, so real fast again, just to finish up here, the maternal psychiatric assessment, what do we do with this? So again, very small studies of these, because again, if it's 2 to 4 per million, it's hard to find 28 mothers with this kind of idea with the diagnosis. And you can see when they did this, a large proportion had their own somatoform disorder. They also had either current or past factitious disorder. Look at that, a third had non-epileptic attacks. That is, they had pseudoseizures. And if you've grown up with somebody who had real seizures, or you yourself have had real seizures, it's not difficult really for you to fake a seizure. And I saw that in psychiatry back in Maryland, a fair amount in residency. We had a group of patients who had been traumatized as children, and that was one of the ways they would present it. It took some time to figure out if it was a real seizure or not. You really end up needing video EEGs on their brains to see if they're actually having seizure activity. And interestingly, sometimes they would, and sometimes it was fake. So that makes it quite interesting. The fancy word, by the way, for this pathological line, which gets applied to Baron von Munchausen as well, is pseudologia fantastica, which is this pathological lies that they tell, and they do it so well it's hard to tell that it's a lie, which again is kind of the common theme here with this factitious disorder, whether it's in yourself or another person. Attachment, they looked at attachment because then you start to wonder, well, what's going on with that between the mother and the child in particular, and you can see a lot of issues that ultimately amount to insecure attachment, and there is a attempt in the literature to use what's called bereavement or stress therapy to try to help some of this, but again, they might be getting some kind of treatment already, but the therapist may not even know that they're making their child sick. Right? So that's not necessarily going to be something that's probably not your normal thing you ask when you're treating somebody, right? Is you just don't go there. Right? There's a lot of things you're talking about. That's not one of them. So the goal of treatment, of course, is to try to modify this mother's behavior to reduce, says his or her, but it's mostly her, overuse of medical resources. You need a trusted gatekeeper, obviously psychotherapy, because you need them to have a trusting relationship with a trained professional to be able to really work through this. And it's a lengthy thing. This is not a 6-session and then managed care is happy with you because you solved it. That's not the way that's going to work. And of course, then you're going to try to work out the underlying psychological issues once you've stopped the overuse of that person or their child with the healthcare system. No medications, sorry, Sarah, but no medications we can talk about with this. I looked for it, can't find it anyway. SSRIs, which show up in the literature having been tried with virtually every mental illness at this point, I think, there's maybe something there. Maybe they help control the impulsive behavior as they would in an obsessive compulsive disorder or something like that. Very, very loose literature on that. And as a result of that, we're really talking about psychotherapy. And unfortunately, that takes so much time. We're talking about a poor prognosis for these individuals. It's very difficult to treat them. Mainly, our goal is going to be to help them not get harmed by seeking out needless medical care, or to not have their child be harmed any further by seeking out that. Looking for detection, one's called the positive separation test. Again, not rocket science. Keep the mother away from the child for a week in the hospital. The child magically gets completely better. Nobody knows why. Child goes home with the mother, magically sick again 3 days later, right? So if you test that twice, you probably have your diagnosis. Unless there's something in the household that's causing the illness, you'd have to obviously verify there wasn't something there going on, black mold or something like that. No surprise in today's world, video monitoring, as we're talking on video as we speak. So talk to the child. Hey, surprise, surprise. Let's ask what's going on a little more directly, even though the child may be 6 years old. You might learn something by talking to the child. And I many times practice with a pediatrician or family medicine. I suspect you tend to have the parent in the room, but maybe there's a situation where you really need to say, I really want to talk to little Joni here by herself for a couple minutes. Would you allow for that to kind of get a better sense of what's going on? And of course, psychological consultation is pretty key here. All right, so child safety first when we're talking about FDIA or Muchasen by proxy. Get all the medical records. That's often something that the parent will try to avoid, right? Because this may have been suspected in 5 other doctors' practices. And when again, if it's a nurse, she may kind of get a sense, oh, they're on to me, again, unconsciously even, and moves practices. So you really have to work as a team and get everybody involved. You may have to get child protection involved, whatever that's called in your area. So Suffolk County Children's Services would be who we'd get if it was in Suffolk County. Here's another, just a couple real quick ones. So here's another one, the ACT. There's another one. This one actually starts off pretty quickly in the episode where the daughter, who had been a victim of Muchasen by proxy, kills the mother. So there is some forensic. Again, Dr. Susan Harris-Friedman brought this to my attention. I think, Nicole, you had mentioned this show, The Act, way back when.
A trailer for it. The Sharp Objects is the one that I talked to you about. Okay. But I've seen the previews for this.
Yeah, so it's also hard to watch. It's very, very, very moving. Lots of stuff. The neighbors are involved. Obviously, the police get involved, but the mothers gets killed and so forth. So the point is here, there could be a circumstance where the child grows up, has a better sense of what was going on, is still under the mother's control, and the only solution they come up with is to kill the mother. So that does happen. Not common, but you can see it here, kind of what I just described. And the child tends to appear overly dependent, but at some point, whatever switch flips, says, I can't do this anymore, and eliminates the person they're dependent on. Again, the father tends to be either absent because they're working or not in the house at all, a fatherless family, or just ineffectual. These are the real people. In terms of that show, The Act. And I will take questions.